My name is Zori Kalibatseva. I'm a faculty member in the psychology program. And I have the honor today to introduce to you our keynote speaker, Dr. Lily Brown. Dr. Lily Brown is an assistant professor of psychology at the University of Pennsylvania in the Center for the Treatment and Study of Anxiety. Dr. Brown received her PhD at the University of California, Los Angeles, and she was the recipient of the National Science Foundation Graduate Research Fellowship, the APA Dissertation Award, and numerous other university grants. She completed her pre-doctoral internship training at Brown University, and her research and clinical interests are in the development and testing of evidence-based treatments for anxiety and trauma-based disorders, particularly in those with high suicide risk. She's interested in disseminating evidence-based practice into the community and in further developing treatments for patients with anxiety at high risk for suicide. On a personal note, Dr. Brown and I met several years ago when I was working at Brown University with her. We were both research assistants there, so we can definitely talk to you about our experience going through undergraduate careers and then working as research assistants. And I also hope that she'll be able to share with you her experience. She has been really highly renowned, and it's a pleasure and an honor to have her here today. Dr. Brown?
So it is such an honor to get to be with you all here today. I was sitting in on the research presentations from the Stockton students just a few moments ago and was so impressed by the caliber of the research that's going on here. You all are doing great things in the field of psychology, so it's a true honor to get to be here today to tell you both about my career path and about some highlights from research projects that I've worked on throughout the recent years. And the goal of my talk today is really not to get into the nitty-gritty of the kinds of projects that I've been working on. Instead, what I hope to impart upon you is the path of my research trajectory and to sort of let you in on the way I think about figuring out what my next research questions are and trying to navigate the complicated path of academia. So to tell you a little bit about myself in terms of background information, when I was an undergrad, I studied at Drexel University, and there most of my research was focused on the treatment of test anxiety. And I was involved in trying to design a randomized controlled trial comparing a couple of different interventions for looking at ways to improve test anxiety in undergraduates. And that was really interesting and really exciting to me at the time, but I realized I wanted to get more experience with more severe samples. And so that's when I worked with Zori at Brown University and Butler Hospital, working with patients who had suicide risk and who had psychosis. After Brown University, I decided I wanted to pursue advanced training in clinical psychology and learning and behavior psychology. And so for that, I went to the University of California, Los Angeles, where I studied with a professor there who specializes in anxiety-related disorders. And from there, I worked in another suicide lab at Brown University before finally ending up where I'm at now at Penn. And so my research to date is really focused on trying to understand why do some people become suicidal, and what are the ways that we can reduce suicide risk for those people who are at high risk for suicide. So to start, anxiety-related disorders are one factor associated with increased risk for suicide. In general, predicting suicide is really complicated. If you ask 100 people who've made a suicide attempt why they made a suicide attempt, you're likely to get very different answers. And over the past several decades, there's been a lot of research trying to understand these different predictors of suicide risk. One that's come out through many studies is that anxiety is associated with increased thoughts of death, increased thoughts of suicide, and engaging in suicidal behaviors. Post-traumatic stress disorder reliably shows up as a predictor of suicide risk in particular. So for those of you who don't know, post-traumatic stress disorder is a diagnosis following exposure to a traumatic event. So after someone's been through a life-threatening episode, a sexual assault, an accident, many people develop the symptoms of PTSD following a trauma. Most of those people experience natural recovery from those symptoms in the first year or so after a trauma. But for some people, these symptoms continue on for many, many years. In fact, some research has shown that if you just let PTSD symptoms sit without treatment, people as many as 50 years after exposure to trauma will continue to report symptoms of PTSD. And there are a number of factors that influence whether or not someone goes on to maintain symptoms of PTSD or not, which are somewhat beyond the scope of what I'm going to be talking about today. But at the end of our talk, I will have time for questions. So if you're interested in talking about that, I'd be happy to. But one thing that we know about PTSD is that if an individual experiences a history of abuse, they are more likely to report having multiple suicide attempts compared to if they do not have a history of abuse. In addition, individuals who have a suicide attempt history, so first of all, women are more likely to make a suicide attempt than men. Men are more likely to die by suicide than women. This is a really interesting phenomenon that's been showed reliably over many decades now. And the primary differentiating factor seems to be method of suicide attempts. So men tend to use more lethal means of suicidal behavior compared to women, and therefore are more likely to die by suicide, but women make more attempts. What's really interesting, though, is if you consider the role of having a history of abuse, men are just as likely as women to make a suicide attempt over time. Interestingly, folks who are middle class or higher socioeconomic status are actually more likely to make a suicide attempt than those who are not. However, if you have no insurance or are on public insurance, things like Medicare or Medicaid, and you have an abuse history, you're just as likely to make a suicide attempt as someone who was already at higher risk than you. So these are some findings that we found in psychiatric inpatients, that history of abuse, history of PTSD makes you more likely to report having engaged in suicidal behavior at some point in the past. But this sample is somewhat unique in that psychiatric inpatients, by definition, are at the very severe end of the spectrum. What about in the average population? If one of our missions is trying to understand ways to predict suicide and ultimately prevent suicide, we need to look at a larger scale and look at it in epidemiological data. So for this project, the next project I'm going to describe, in terms of the background of how I got to this project, I was an intern, which is the last year of my clinical psychology training, and I was sitting in a chart room writing probably my millionth note that week, feeling totally burnt out, totally tired, and a psychiatrist walks into the room, and his name was Robert Cohn, and he's a prolific public health researcher at Brown University who's done amazing studies. And he walks in the room and he plops down on his desk and he says out loud, I think hoping no one would hear, I wish someone would analyze my data for me. And here I am sitting in the chart room with a lot of statistical background, with a lot of experience in how to analyze data, and I pull my chair back from my desk and I seize this opportunity and say, I will. And as a result of being in the right place at the right time and being willing to take on these extra responsibilities, I had the opportunity to do a really cool study. You see, Robert Cohn was involved in a major multi-country study trying to look at predictors of depression over time. And as part of this trial, he recruited over 3,000 folks from Chile. And he measured them multiple times, beginning around 2003, then a year later, and a year after that. Now, many of you may know, in 2010, there was a major earthquake that struck just off the coast of Santiago in Chile. And this earthquake caused a major tsunami and severe destruction in the city. And folks who had participated in this trial, starting 10 years before about, were exposed to a major natural disaster. And so Robert Cohn and his team seized upon this opportunity to try to understand what happens for folks before and after natural disaster exposure. And a research question that I became interested in is trying to understand the extent to which prior trauma exposure affected negative health outcomes after this natural disaster exposure. And we found something really interesting. So here I'm graphing folks who had a diagnosis of PTSD totally unrelated to the natural disaster. This was 8 years before this natural disaster. And they had rates of PTSD related to all kinds of negative traumatic events versus people who did not have a baseline diagnosis of PTSD. And what you'll see is that at baseline, this first assessment, folks who had a diagnosis of PTSD had greater thoughts of death and greater thoughts of suicide compared to people without a diagnosis of PTSD. But what becomes really interesting is if you follow these folks over time, this is the part between this assessment and this assessment, the natural disaster occurs. What you see is for the folks who have a diagnosis of PTSD, there's a significantly steeper increase, both in thoughts of death and thoughts of suicide compared to people who didn't have a diagnosis of PTSD from the get-go. So what does this mean? Well, it means if you have exposure to trauma and you develop symptoms of PTSD, it's possible that experiencing subsequent negative traumatic events is more likely to result in negative health outcomes. And so if we're thinking downstream in terms of who do we need to target for prevention efforts, in terms of suicide prevention, this group might be a particularly important group to target, those who already had exposure to PTSD. And so these projects led to the next several years of research in terms of looking at a couple of key research questions. So the first one was, if we know that post-traumatic stress disorder leads to greater risk of suicide, and, by the way, we know that there are many treatments out there that are really helpful in reducing PTSD, do those treatments have a positive benefit in terms of reducing suicide risk? And if they do, what are the mediators of this suicide change? So mediator is a fancy statistical term. It basically means what drives the change in suicide over time. So the rest of the projects I'm going to describe to you focus on these two main research questions. And so I began this topic by looking at a sample of adolescents in particular. And to let you know how I stumbled into this opportunity, when I was looking for a job after graduate school, I applied to a number of different places, but I knew I wanted to end up in a research lab where I had a chance to capitalize on previously collected data. One of the things you'll find out if you're interested in pursuing a career in research is that it takes a long time to collect rich data. And so if you can collaborate with people who are more senior than you, who've already invested tons and tons of resources and money and time into collecting this data, and they're willing to let you use it, take those opportunities. That's a really important thing that I've been able to do over the past years. And so for this project, I was working with my current boss. Her name is Dr. Edna Foa. And Dr. Foa developed in 1999 a treatment designed for post-traumatic stress disorder. And this treatment is called prolonged exposure therapy. The name of it isn't especially important, but what is important is the concept behind prolonged exposure. The idea here is many people who experience a traumatic event, who go on to develop PTSD, will tell you their natural response is to do whatever they can to not think about the trauma. In fact, this is sort of common sense. It makes perfect sense that if you've gone through something awful, why in the world would you want to talk about it? Why in the world would you want to think about it? However, avoidance of trauma-related cues in the long run it contributes to the development of PTSD and to the maintenance of PTSD. So this prolonged exposure treatment, the goal of this treatment is to help with processing a traumatic event. It's what we call a trauma-focused treatment. It targets the trauma. And so she developed a study in 2013 trying to look at the efficacy of this treatment for adolescents. And for this project, she teamed up with an amazing center through Philadelphia. It's called WAR. It stands for Women Organized Against Rape. And it's a unique, one-of-a-kind center that is focused on providing resources to survivors of sexual violence, both men and women, and trying to offer group counseling, individual counseling, prevention workshops all throughout the city of Philadelphia. Through WAR, the participants that are involved at WAR are both adolescents, so beginning around age 13, and adults. For the study that Dr. Foa worked on, we targeted adolescents specifically. And so for this study, we're looking at female adolescents who had been sexually victimized in some way, who then went on to develop symptoms of PTSD. And we basically measured a variety of symptoms over time. And for this study, I'll be talking about measures of PTSD symptom severity and measures of suicide severity. Just so you know, the treatments basically were 14 different sessions that were between an hour to an hour and a half each. And the study compared this trauma-focused treatment, PE, to what's called client-centered therapy. This treatment is basically supportive counseling. It's not trauma-focused, you don't process the trauma. It's focused on building a relationship with the therapist, processing daily stressors. It's non-directive, it's led by the client. The main outcome results from this study came out in 2013 and basically reported that this trauma-focused therapy, PE, here on the left, was more effective at reducing symptoms of PTSD compared to client-centered therapy. This is a finding that's been replicated in several other kinds of studies with several other kinds of patients, but certainly not in all studies, and I'll talk to you about some of those as well. And so this is all well and good, but coming back to my research question, if we know that this treatment, PE, is associated with significant reductions in PTSD, well, what about other negative health outcomes? It's great if we can improve PTSD symptoms, but people who have PTSD are often very complex. They have higher rates of medical problems, they have higher rates of other psychiatric diagnoses, and they're at greater risk for suicide, as we've already talked about. So of course, I wanted to know what happens in terms of change in suicide rates and suicidal thoughts over time. And so I'm not gonna get into the details about this, but basically, this gray line here is folks in the PE condition, and this black line here is folks in this supportive counseling condition. So trauma-focused treatment is in gray, non-trauma-focused treatment is in black. What we find is that folks who got this trauma-focused treatment had a steeper reduction in thoughts of suicide over time. You can think of it like if they were randomized to receive this intervention, their thoughts of suicide got better faster if they were in the trauma-focused treatment compared to not. And they tended to maintain their gains over time. To this other question, though, about what drives change in suicidal thoughts over time, what we found was that there was a significant interaction between time and PTSD symptoms. So what does this mean? It means if your PTSD symptoms got better faster, your suicidal thoughts got better faster over time. Now this is just one potential variable to look at, and I'll go through some other studies where we look at comparing a variety of other potential drivers of suicidal reduction over time. But this is one step getting us closer to determine that if you can effectively manage symptoms of PTSD, for people whose suicide risk is tied to their trauma, you can actually reduce thoughts of suicide, and that's really important. Now, many clinicians who work with post-traumatic stress disorder will tell you that they're often worried about engaging patients in trauma-focused treatment. They'll tell you that this is especially a concern when patients are complex, when they have suicide risk, when they have emotion dysregulation. Many therapists are concerned that having patients talk about what they've been through is going to exacerbate their symptoms. It's going to make them worse. And if we're thinking about patients who are at high risk for suicide, well, this is really scary to a clinician because people who get into therapy as a counselor usually do so because they want to help people, and they're very concerned in many cases about doing anything to make the situation worse. So by and large, trauma-focused treatments have been contraindicated, meaning we suggest you don't do this for people who are at risk for suicide, without any real data to suggest that trauma-focused treatments actually increase risk for suicide. So this is a really interesting sort of policy decision that's been imparted in our field for quite some time. So we looked at rates of what we call exacerbation of suicidal thoughts, so people who had thoughts of suicide, how many of them got worse? And for people who denied thoughts of suicide at baseline, how many of them eventually went on to report thoughts of suicide? These are two different ways to think about gauging getting worse. And what we found was that if we compare our client-centered therapy, this is again our supportive counseling, rates of exacerbation were about a third of participants, and new onset were about 10%. And consistently in our trauma-focused intervention, rates were lower, not statistically because this was a relatively small sample size, but there was no evidence from this study to suggest that talking about a trauma is more likely to make someone think about suicide who wasn't already thinking about suicide, or just in general. And this is really encouraging but still promising research in this, but still new research in this area. So that's exciting because adolescents are at higher risk for suicide compared to adults, by and large. But this study had a number of limitations to it. So first of all, it only included adolescents, and so the obvious question is, well, okay, fine, how about adults? Also, as you might recall, this sample of adolescents only included females. But men are more likely to die by suicide than women. So the natural extension of this research is to look at a male sample and to try to understand what happens in terms of changes in thoughts of suicide there. And so for this study, in our research laboratory, we work a lot with the military. We have a number of studies going on with folks who are active duty between deployments. And so these individuals are home from deployments, have a diagnosis of PTSD. Sometimes that's related to their service, many times it's not. And they're seeking treatment for their PTSD in between deployments. The reason is, if you have a diagnosis of PTSD, your threat detector receptors are off. You're more likely to see threat in situations that aren't threatening. And you're more likely to act on that threat in situations that don't warrant it. So PTSD can directly impact your behavior in situations that are high stakes, like being a military service member. So for this study, we recruited a very large sample of 366 participants who were post-9/11 service members who had a diagnosis of PTSD. The main outcome results for this study were published in JAMA, the Journal of the American Medical Association, several months ago now, I believe it was in January. And those study results basically suggested that this PTSD trauma-focused treatment resulted in significant reductions in PTSD symptoms compared to a waitlist condition. But I'm really interested in trying to understand what changes in terms of suicide risk over time. The design of the study was complicated, but I'm going to make it really simple for you. Basically, we're interested in two comparisons. The first comparison is looking at a trauma-focused treatment compared to supportive counseling. This is pretty similar to that adolescent study that I showed you before. And then also a trauma-focused treatment compared to basically waitlist, doing not much of anything. And so what we found is for this first comparison, trauma treatment versus waitlist, if you received trauma-focused treatment, here in black, you had a significantly faster reduction in thoughts of suicide compared to if you received this supportive counseling intervention. And by and large, those gains were maintained in a follow-up period. Furthermore, if you had greater reduction in PTSD symptoms, you had even faster reduction in suicidal thoughts. In terms of our comparison for trauma treatment versus supportive counseling, what we found is that in both conditions, there was a significant reduction over time in suicidal ideation, and there wasn't an interaction between conditions. What does this mean? It means both conditions effectively reduce thoughts of suicide. But folks who had a greater reduction in PTSD symptoms also had a greater reduction in thoughts of suicide. So the story so far is actually fairly consistent. In terms of rates of exacerbation between these conditions, so this is our supportive counseling intervention, this is a trauma-focused intervention, this is waitlist, and this is trauma-focused. What you can see is that there's no evidence for enhanced rates of suicide exacerbation statistically compared to supportive counseling or doing nothing at all. Furthermore, rates of suicide attempts were really comparable across all the conditions. So if we're trying to understand what drives changes in thoughts of suicide, one natural symptom change to pay a lot of attention to is symptoms of depression. In fact, most people, when they think about suicide, think about depression, but certainly not all people who die by suicide meet criteria for depression because, again, suicide is extremely difficult to predict. So I published a study recently where I was trying to understand the temporal relationship, or the relationship over time, between symptoms of PTSD and symptoms of depression. The basic idea is this. If in a therapy we have measures of PTSD at a given session and measures of depression at a given session, what leads to what? Is it that depression at this session leads to PTSD symptoms later, or the opposite, or that both directions are important? And there's a complicated statistical way to do this. And in terms of thinking about the path that I took in figuring out career-wise what I wanted to do, when I was in graduate school, I took a class with an amazing statistics professor. Her name was Jennifer Kroll. And she spent hours with me teaching me how to do this very analysis for a totally unrelated research question. She taught me how to use 3 new statistics programs that I had never used before, and she was extremely generous with her time. When you meet a professor like this, who's willing to sit and teach you things and show you how to answer complicated questions, go with it. Spend as much time as you can with that person. I cannot explain enough how many people like this have impacted my career to a great extent. And what was amazing was that she taught me how to use this statistical method, and now I'm able to use it to answer a number of other kinds of research questions, and I don't need her help anymore because she taught me so much. So for this project, I'm not going to go into all the details of this graph, but basically what I found was across 3 large-scale randomized controlled trials that I put all together looking at PTSD treatment, that the degree of PTSD symptoms on a given session predicts depression the next session. That makes sense, but also the opposite was true. So how depressed you are now is a predictor of how your PTSD symptoms are going to be next week, and vice versa. There seems to be this reciprocity or back and forth relationship between these 2 constructs. So in terms of trying to understand what drives suicide change over time, this reciprocity seems really important. So to better understand what drives changes in suicide over time, I took this active duty military sample and I collected a number of different kinds of measures. So we have measures on PTSD, like I already told you about, and we also have measures of depression. There is a totally separate area of research, though, on the relationship between a number of other constructs and suicide risk. One of those key areas that have come out is around the relationship between sleep problems and suicide. In fact, the highest risk time for suicide is in the middle of the night. Some studies show between midnight and 6 a.m., some studies show between 2 and 3 a.m. Being awake at the middle of the night is a predictor of not engaging your executive functioning skills, being more emotionally dysregulated, feeling more disconnected from people, and all of these things are probably important for understanding suicide. And so when they look at these large-scale mortality databases, they find that indeed the middle of the night is a high-risk time for many individuals. So I wanted to include insomnia and nightmares for trying to understand whether this is more strongly driving the change in thoughts of suicide in this sample. And to that end, I didn't know much about insomnia. It's a whole other area of research that is related to PTSD, but it's very distinct and very different. And so to do this, I was on a research call with a number of different principal investigators for this big deal trial that we were working on. And there's a lot of egos on this call, there's a lot of opinions on this call, and I'm explaining the kind of research project that I want to do. And I'm describing how I plan to do the research project and how I plan to measure suicide over time. And all of a sudden, I hear a thick Louisiana accent of a researcher who I've never talked to before, and he says, I want to know how you're going to measure suicide. And I was taken aback because I didn't know who this person was. And it turns out it's my great collaborator and friend now named Daniel Taylor, who's a researcher at the University of North Texas, who's Louisiana strong and proud and would not mind me doing his accent. I do it all the time with him now. And he is an expert in insomnia. And it wasn't until I started working with Daniel that I realized how little I knew about sleep disorders. It's a really complicated area of research. And him being on that call with me at that time was another opportunity that presented itself that I said yes to. After that call, Daniel looked me up and realized that we had both been at Brown University at a variety of points in our career. And so he reached out to me and said, do you want to collaborate on some research projects? And so we've been collaborating ever since, and it's been a really fruitful relationship. In this model, though, we're also interested in a couple of other important predictors of suicide. So these include social support. In fact, major theoretical models of suicide suggest that the ability to connect with people and the sense of being a burden on people versus being a contributor is an important predictor of whether someone's going to think about suicide. And so it's likely that these two indicators of social support and unit cohesion could theoretically be linked to change in thoughts of suicide over time. And so long story short, we ran these complicated statistical models with Daniel and I and some of my other friends. And after including all of these different variables, you put it all in but the kitchen sink. What turned out was that the most important contributor in this model was depression. But if we take it a step further, what we found was that changes in PTSD symptoms lead to changes in depression, and that those changes are what drive change in suicidal thoughts over time. So this is an example of how you start with a really complicated model and you draw on your collaborators and you draw on outside experts and you try to help come to a closer approximation of reality. But what about in terms of naturalistic samples? So we've done a lot of work on trying to look at suicide in adolescents, in active duty military. What about in civilians, in treatment-seeking patients who just come into our clinic? So at the CTSA, we have a large clinic of patients presenting for treatment for anxiety-related disorders. And we do a number of research projects in collaboration with these participants to try to understand how our treatments work and also that they work. And we know that anxiety in general, beyond just PTSD, is associated with increased risk for suicide. So several years ago, I published a paper with my collaborators at Brown showing people who have panic disorder, in addition to depression, have higher rates of thoughts about suicide, that's here, and higher rates of suicide plans. And the comorbid diagnosis of panic disorder is associated with a greater likelihood of having made a suicide attempt at some point in the past. So it's not just PTSD that's associated with higher risk for suicide. In fact, across the literature, a number of different anxiety-related diagnoses have been associated with suicide risk, including there's some studies suggesting social anxiety is tied to higher risk for suicide, some showing generalized anxiety, and some showing OCD. So what we wanted to do was we wanted to follow our treatment-seeking participants over time and to see what happens to their thoughts of suicide in treatment. And in terms of our diagnostic breakdown, we had a diagnostically diverse sample of participants here. About a third of our participants had a primary diagnosis of obsessive compulsive disorder, or OCD. In terms of baseline differences, what we found was that folks who had a diagnosis of PTSD had higher thoughts of suicide, higher severity on that measure, compared to folks with specific phobia. Interestingly, our social anxiety group had a similar effect. And if we look at changes over time, what we found is that across all diagnoses, there was a significant reduction in thoughts of suicide in response to anxiety-focused treatment. But there was also an interaction with treatment, or with diagnosis rather. So there's a significant reduction for those with PTSD, social anxiety, and this other anxiety category. But for other diagnoses, there was not a statistically significant change over time in thoughts of suicide. And to just show you graphically, this baby blue line here is PTSD, this is social anxiety, and this is our other anxiety diagnosis group. And if we look at collapsing across regardless of whether someone has PTSD as their primary concern, do they meet criteria for that disorder at all? What we found is that only PTSD was associated with significant reductions in suicidal thoughts over time in treatment. Rates of suicide exacerbation were generally low, And when they did occur, it was more likely that they actually occurred in the context of obsessive compulsive disorder, which is really interesting. In fact, until 2016, the clinical lore out there was that OCD patients did not have higher risk for suicide. And then in 2016, there was a major meta-analysis that showed the opposite and showed that indeed, most psychiatric disorders are associated with higher risk for suicide, including OCD. So in the last few moments I have here, I'm going to talk a little bit about my future research directions, and I've been working a lot with my colleague Daniel Taylor to try to figure out ways to better understand the relationship between sleep and suicide over time. And a lot of our research, as I mentioned, is in active duty military personnel. And that's of high relevance here because 1 in 5 service members meets criteria for insomnia. Many service members, regardless of whether they have PTSD, report nightmares, about 1 in 4. And of service members who present to a sleep clinic, 4 out of 5 of them will indeed meet criteria for a sleep disorder. We know, as I mentioned, that insomnia is associated with higher rates of suicide, both in terms of thoughts of suicide, suicide attempts, and actually death by suicide. In fact, there have been some studies that show having a prescription medication for sleep is associated with higher risk of suicide. But there are many questions that remain here because most military service members who have a sleep disorder don't die by suicide. So it's not a clear predictor of suicide risk. So what's going on with those who do die by suicide? So one question to potentially pursue, and we've written a grant on this very question that we're waiting for feedback on right now, is does the perception of having a sleep problem predict suicide risk to a greater extent than objective measures of suicide problems? So for instance, if we have this model where someone says, well, I think I slept poorly, but another person actually slept only 5 hours in the prior night, which of these more strongly drives thoughts of suicide? And for that matter, suicidal behaviors? We don't really know. The second question is, are there certain thresholds after which risk for suicide exponentially increases? So hypothetically, if we were to map insomnia severity on suicide risk, is it the case that there's this linear increasing relationship over time? The more sleep disorder symptoms you have, the worse your suicide risk? Or is it instead like this, where maybe I'm fine until I get to a certain point, at which case my risk greatly increases? This is something that we don't know the answer to. What differentiates those who think about suicide and those who have a greater relationship in sleep-related problems and suicide? There could be a million different variables that drive the relationship between insomnia and suicide, and we just don't know what those are yet. And are some symptoms really good at predicting whether someone's going to think about suicide, but bad at predicting who's going to act on that? In fact, in the suicide field in general, we do a pretty decent job of predicting who's going to think about suicide. Turns out that that's relatively easy to do. Predicting who's going to transition from those thoughts to engaging in suicidal behavior is a big black box of uncertainty at this point. And if you're interested in trying to carve out a niche of research or clinical training for yourself, that's a really interesting area to get into because we know very little about this at this point. Many of the prior studies on the relationship between sleep and suicide over time have a number of limitations, some of which are listed here. And so what do we need? We need to do studies where we look at intensively monitoring patients over time, where we look at comparing objective measures and subjective measures, where we look at non-treatment seeking samples, because if we're interested at reducing suicide risk at the level of the general population, we can't just focus on those patients who come into our clinics seeking help. We need to broaden our lens for prevention efforts. So I'd just like to thank all of my collaborators for all of the help that they've given me throughout my many years of research training. I would say my connections to amazing collaborators over time has been a major driver of my success, and I built those connections by talking with people, taking the advice of people who had lots of advice to give me, and doing lots of hard work. But without the success of these people, without the hard work of these people, I would have never gotten to where I'm at today. So thank you very much.
Why do you think suicidal thoughts have increased throughout the years?
So I'm not sure that they have. So it's interesting. Epidemiological data suggests death by suicide has increased over the past decade. And that's interesting because it's been a major public health initiative to try to reduce death by suicide over that same time period in which death by suicide has increased. Like a lot of psychological problems, I'm not sure whether this is an issue. Your question was about, do we know why are thoughts of suicide increasing? I think it's possible that individuals are more willing to disclose thoughts of suicide now that we have language for how to describe it. We have national suicide crises hotlines, which, by the way, if you Google the word suicide, fortunately, it's the first thing that comes up is a 24-hour staffed suicide prevention hotline. I'm not sure that thoughts of suicide have increased. I think it's possible that more people are willing to talk about it. We know, though, that death by suicide has increased. So is it that that's because more people are thinking about it? Is it that there's different access to lethal means than there ever has been? Is it something else? I don't know, to be honest, but it's a really interesting question. If you're trying to think strategically again about what area of research to get into, this is going to be one that is going to continue to grow, and it's one that is growing in terms of the number of researchers working in that area, but there's lots of room for young investigators to get involved in it. And one resource for trying to figure out potential opportunities for research is the American Foundation for Suicide Prevention, which is a national organization. They have a great website with all kinds of resources on it. And if this is a topic area of interest to you, I'd encourage you to look at that website.
I found your research very interesting. I work in a correctional setting. I've been there for 35 years. There's a very high risk of suicide in correctional populations. We are tasked with identifying those people and making sure that it does not happen. We also have a growing population of veterans with post-traumatic stress syndrome. So this just gave me food for thought that, you know, there's work to be done in linking that thought for identification.
I totally agree with you. And given that, we've started 2 different initiatives through my center focused on this very idea. So one is we're putting in a research grant in June in response to a call from the National Institute of Health looking at ways to reduce risk of suicide specifically in juvenile justice settings, and not necessarily incarcerated juveniles, but instead juveniles on home confinement and living in the community, because there's a lot of research to suggest that juveniles involved in the legal system are at significantly higher risk for suicide. And yet the reality is there's a lot of victim blaming that goes on with folks in the juvenile justice system. And to date, there has not been a ton of resources allocated specifically to reduce risk of suicide in that sample. I think the good news is the National Institute of Health is catching on to this and is investing research funds and trying to help youth in this way. But our project is basically trying to just understand the scope of the problem, because we have some information on it and there's a lot that we don't know. The other thing that we're trying to do now is a project that we started about 6 months ago, where we're working with judges at the level of, so there are certain judges who work in what's called a mental health court. And there are some individuals involved in the corrections setting that get referred to mental health court based on the presence of a psychiatric diagnosis or condition that otherwise affects their planning. And we're doing interviews with these judges to try to understand the extent to which PTSD influences their plans for offenders. And we're trying to understand the degree of awareness that judges have about evidence-based treatments for PTSD, because these treatments are out there, but they're by and large not being implemented in corrections settings. That's not true across the board, but by and large, it characterizes the current situation. And we're interested in trying to understand the perspective of judges toward whether they think PTSD is even treatable. And so I think there's a lot to be done in that area. It's also a growing area of interest for me as well.
I might also add that correction officers are at a higher risk than the general population for committing suicide. So we do a lot of training and interventions, particularly if there's an event in the jail that occurs.
Yeah.
So that's another very interesting group, and we try to do all we can to help them in terms of their mental health, because it's a tough job.
Yeah, I agree. In fact, in October, I gave a presentation at Fort Dix, the Fort Dix Correctional Institute, the federal correctional facility there, where the majority of the corrections officers are veterans. And so they had a veterans mental health retreat day where they asked me to come and speak about what is PTSD and how to recognize it for this very issue that, as I described, if you have a diagnosis of PTSD, there are times in which your perception of threat is altered in a way that can actually accidentally worsen a situation. And there are times when that threat detection being off is actually really helpful to your survival. And so it's all about trying to figure out ways to help people strike a balance in their perception of threat, and I think that's really relevant to the corrections.
And a lot of our corrections officers come from the military. So.
Exactly, yeah. So thank you all very much for your time and attention today. I appreciate it.